We'll go ahead and get started. So welcome everyone to Best in Class MD's webinar on emerging opportunities in digital musculoskeletal health. I'm Ben Wachuku, and I'm going to be the moderator for this webinar. I'm honored to be joined by my esteemed colleagues who I'll be introducing here shortly. And so what are we going to be talking about today? We're going to talk a little bit about what is Best in Class MD for those that don't know. And then we're going to talk about the physician experience with digital health. We're going to discuss as a panel some of the reasons why the spend is so high in musculoskeletal health. And then we're going to talk about musculoskeletal digital care pathways and the patient journey. And then we'll have time at the end for question and answer. And I would encourage everyone to be thinking of questions that you may have as we go along, and happy to pose it to our panelists. And so I'm honored to be joined by my esteemed panelists. So a little bit about myself. So I'm Ben Wachuku. I'm co-founder, co-CEO of Best in Class MD. And I am an orthopedic sports medicine surgeon and associate professor at Cornell Medical School. And I take care of professional sports teams. We're joined by my co-founder and co-CEO, Dr. Riley Williams, who is an attending orthopedic surgeon at the Hospital for Special Surgery, as well as a full professor at Cornell Medical School. He is the head team physician of the Brooklyn Nets, New York Red Bull, and USA Basketball. We're also joined by Dr. Holly Johnson, who is an attending orthopedic foot and ankle surgeon at the Hospital for Special Surgery. She is team physician for USA Women's Ice Hockey and the New York Liberty. And then we are also joined by Dr. Andrew Heck, who is the chief of spine surgery at Mount Sinai Healthcare System, professor of neurosurgery. He is the director of the NFL Spine Care Program, surgical consultant to the New York Jets, Islanders, and Dragons. And then Josh Williams is also joining us. He's a senior director overseeing all clinical operations at Figure 8. Figure 8 is a channel partner to Best in Class MD. And Josh uses 18 years of clinical experience as a physical therapist to help Figure 8 with their team design and develop strategic objectives. So thank you all for joining on this webinar. So a little bit of a background introduction. So what is Best in Class MD? So before we can talk about what Best in Class MD is, it's important to understand the state of the healthcare landscape. So the problem traditionally was that the provision of medical opinions was done in the brick and mortar, meaning in the traditional silos of the hospitals, and there was limited opportunity for care coordination, expert medical opinion, and really lack of access to leading minds, because oftentimes leading minds were siloed in various institutions and geographic locations. Well, what we know is that with COVID-19, there became a rapid adoption of digital healthcare options and a disruption to the traditional brick and mortar. And so what we saw at Best in Class was an opportunity to connect the consumers directly to health specialists who could provide the best care possible. We started with musculoskeletal, and why do we do that? Well, we know that musculoskeletal problems represent approximately 50% or are present in 50% of Americans. And that may seem like a high number, but truly 1 in 2 Americans has a musculoskeletal problem, whether that's chronic back pain, knee pain, or an acute injury. And as a result, we know that musculoskeletal problems are a major cost driver in our US healthcare system. Approximately $213 billion in lost wages and productivity each year is incurred as a result of musculoskeletal problems. And we know, unfortunately, that surgery for musculoskeletal conditions are overindicated. And I guess germane to our audience today, musculoskeletal problems really disproportionately affect workers. 50% of musculoskeletal injuries are reported in manufacturing and service industries. And these result in approximately 130 million inpatient ER and hospital visits. And so our mission at Best in Class is really to create a front door that begins with access to expert care. And to do that, we assemble a national network of top 1% providers assembled on a facile telehealth platform to drive engagement and value for our clients. You might ask yourself, well, what constitutes top 1%? Well, we have a criteria that we use to recruit and enroll our BICMD physicians. We look for physicians coming from top-ranking institutions who have trained at top-ranking fellowships, residency programs, and did their schooling at top-ranking medical schools. We also take into account the H-index. So the H-index is a research measure because we want physicians who are grounded in the latest literature and are practicing evidence-based medicine. And then we also look at extended statistics on surgeon quality, such as statistics for infection and complication rates. And then we have a clinical panel that really looks to understand, what is the reputation of our BICMD physicians in their respective fields. We have over 250 clinical experts, and we have a strong geographic footprint. We are represented in over 46 states and across a diverse medical specialties. Specific to musculoskeletal care, one of the things that we pride ourselves in is that we really follow our data. When you look at our internal data, we know that there's an 80% change in treatment plan. And so what does that mean? It means that we may not necessarily change the treatment plan, but we add modifications, tweaks, and give options in ways that can overall impact and improve the quality of care. 57% of our cases result in the recommendation for non-operative care. And then we have a 30% surgical diversion rate. So what does surgical diversion mean? Surgical diversion means that in 30% of cases where patients were recommended for surgery, BICMD is resulting in a recommendation for non-surgical care. And ultimately, we have shown that it results in a 30% faster return to work and MMI, maximum medical improvement. When looking at our internal data, we save on average $30,000 per consultation. So that's the background on best-in-class MD. And I'm going to move on now to pose some questions to our panelists. So one of the questions that I get quite frequently from some of our clients is looking to understand how the transition to digital health has changed clinical practice. And for me personally, the transition to digital health has really allowed me to provide the work that I do to a vaster network of people around the country. And so we'll kick it off by posing this question to Dr. Hecht. How has the transition to digital health changed your clinical practice? Dr. Hecht, I think you're on mute.
We were forced, all of us were sort of forced to engage in digital health when COVID hit, when we could not get access to our offices or to patients, but yet we had to take care of folks. And we really forced us to really think about what's important when seeing patients. Can we do this accurately, virtually? And we found that during this time, we were really good at this. By engaging someone online virtually, we could get a history, we could do even a limited physical exam. And if we had access to their studies, which they can digitally upload, we can make a high quality diagnosis most of the time, and institute care, whether it be conservative care or make recommendations to folks to get treatment started accurately and effectively.
Yeah, that's a really great point. And I know that at the start of the transition to digital care, a lot of people were sort of anxious about whether digital care was as good as in person and whether you could have an equally accurate diagnosis. So I appreciate that. And I guess I'll also ask the same question to Dr. Williams. And Dr. Williams, I know that you have, as with all the other panelists, but you have a national footprint with your care of professional athletes, people coming from across the country to see you. How would you say that the transition to digital health has changed your clinical practice?
Well, it's just made it more formalized in terms of how we keep records. A lot of times in this world, there's a lot of sidebar consults and texting of imaging studies and notes and things like that. So the adoption of these basically virtual first opinions and virtual second opinions has obviated the need for travel on the part of patients. It serves as a virtual introduction as people are essentially interviewing people who they want to have take care of them. So So I think in two ways, it really hasn't changed my practice in as much as it's allowed quicker access and an execution of the healthcare episode formally. But it's been great, and I agree with Dr. Heck that we were kind of forced into it, and I had never heard of Zoom before COVID started, so we're all sort of Zoom experts now, and I'm just very pleased with this expansion, because essentially digital health in my practice has allowed people who maybe would not have been inclined to engage me. It's just basically an elimination of some barriers that I think were there before.
That's very helpful. And one of the questions that we got from our audience was, in our transition to digital health, how do nurses or health technicians support the consultation? And with the sort of the follow-on being that they are very important to an in-person visit. And I can give my opinion on that and welcome any other thoughts from our panelists. But one of the things that we found at Best in Class is that we have essentially incorporated the traditional nurse role or health technician role into the services that we provide. And we call these virtual care facilitators. And these are nurses who help with making sure that the provider has everything that they need for the visit, whether that's through an updated MRI, uploaded MRI, all the right slices, tracking down the medical records, and even just letting the patient know when their consult is and when to log on to the platform. All right, perfect. So, so transitioning a little bit, and I guess this is this is a bit of a follow-on to the last question, but what are the things that you need for a successful virtual second opinion, and how do you ensure the quality of that? And so I'll throw it back to Dr. Hecht. As a follow-on, what are some of the things that you might need, especially for something like spine and neurologic surgery, where some may argue that you really need to have the person in front of you to actually do a successful visit?
Thanks, Ben. We really realized that we needed, first of all, any records that you may have had. And second of all, what's really nice about digital health is it's really a very imaging intense type of experience in spine surgery. So if we had access to your imaging and any treatments that you may have had, and then we had an online engagement, sort of hearing in your words, maybe doing a very limited assessment, we were incredibly good at rendering a second opinion, and very often could save you from surgery, recommend some untried conservative care that might be very successful to you, or sometimes a totally different type of surgical approach that might be less invasive or less morbid. So it's really not a big barrier to entry. And I think most of us have sort of incorporated this almost routinely now into our everyday practices.
Yeah, no, that's a really good point. And then the follow-on of that, how do you ensure quality with remote consultations? I would say that on our side, we ensure the quality based on our network. We have I mentioned having the things that we look for to incorporate physicians into the network. The reality is that there are some physicians that are actually may not be suited for a digital healthcare approach, and being able to relate to a patient on a video visit, I do think is an art form, and making sure that you still establish that doctor-patient relationship, I think is very important. And we solicit feedback from our clients on the physicians, and we've been very fortunate to find doctors who basically lend themselves well to the virtual approach, to the digital care approach. But there are tools that are being developed and created to augment the digital healthcare approach. And so, Josh, wanted to maybe have you give us a little bit of insight into some of the things that potentially could augment a clinician's digital approach?
Thanks, Ben, and thanks for having me here today. I think, picking up on the thread that Dr. Hack shared, there's things that can be done asynchronously, making sure that you have access to the full medical record, access to high resolution imaging studies, simple things like today where you have a stable internet connection, video, appropriate lighting so you can see and hear someone while they move. But as he also shared, there are some limitations to doing, a full physical exam. And I think really have been advancements in technology, and whether that's hardware, in software, in computing power, that allows the accessibility of ways to collect some of that data that you traditionally collect as part of a physical exam. And so whether that's things that are camera-based, whether that's wearable sensors that are connected to a mobile device. There have been advancements now where you can facilitate the capture, the recording, and the reporting of really high fidelity movement data that can be shared as part of that synchronous or asynchronous digital encounter. And really, that's what we're doing here at Figure 8, is helping to set a new data standard for MSK health and bringing that to any points of care to make it accessible.
Thank you, Josh. That's very helpful. All right. And so as we think about, second opinions and digital healthcare landscape, a question that we often get is, in what clinical situations are second opinions helpful? I would say that, just based on the available data, we know data out of Mayo show that 62% of second opinions result in, a modification in the treatment plan. And, I told you earlier that our internal data is 80%. And so we think that second opinions in general are helpful in most clinical situations. There's clearly a benefit, which is why I think that there's also an ask of other sorts of digital options, such as impairment ratings, or maximal medical improvement evaluations. And so specifically for clinical conditions, I'll ask you, Dr. Johnson, are there scenarios in which you think that second opinions could be helpful?
Absolutely. I mean, in foot and ankle, just like in any of the other orthopedic subspecialties, imaging is so crucial, and probably 90% of the time can really guide your judgment or opinions. And so if we have access to good imaging, the patients that I'm often seeing in the clinical situation like this is not really even a second opinion, but often a third or a fourth opinion. So, I'll have patients that have gone and seen 2 different doctors and aren't really sure where to go. And as the expert, I can really guide them in the right direction. As a foot and ankle orthopedic surgeon as well, I see and consult with many patients who are on track with a podiatrist who may not really be the right care provider for them. The situation may be more complicated or beyond the scope of a podiatrist. And so in those scenarios, I'm often able to guide the patient to a more relevant type of provider. And being in this situation in academic medicine and knowing people really all over the country, if I'm consulting with someone far away from myself, I can often look in my database of other orthopedic foot and ankle surgeons and even send them in the right direction locally. And I've done that quite a bit. And I think that we've been able to manage patient situations much more effectively. And then lastly, sometimes patients have a really great opinion and they come and they just need simple reassurance, whether it's non-operative or operative suggestions from their original provider. Sometimes I can just reassure them that, yes, you are getting excellent care, continue in this direction, and you're really on the right track.
That's very helpful. And, that picks up on a thread that sometimes we will hear from some of our enterprise clients, where there can be a concern about getting a second opinion out of, a fear, I should say, of offending the first opinion or the first doctor. And so, Dr. Williams, we'd love to hear your opinion, just being a high volume second opinion person, for the knee and for the shoulder. What's been your experience with other doctors when their patients come to you for a second opinion?
Well, I don't know if my experience is super germane. A lot of times, I'm sort of the last opinion because of my availability. So sometimes they can get in and see patients a little more quickly than they can with me, and so they'll come to me already maybe having had one or two and with some suggestions. And I agree with Dr. Johnson. Sometimes they're just looking for verification. But I think the main role here as a tertiary care physician is that the formalization of the pathway just allows for the rendering of a really good, well thought out opinion. A nice thing about all the panelists and folks that are involved with BICMD is, for the most part, we have narrow practices with a high degree of specialization in the chosen field. So I typically can tell just from the story, kind of like what the germane one or two issues are going to be, and then as has been stated on the call or in the webinar today, just using the imaging studies and notes and things like that, and maybe a cursory assessment to figure it out. But the sort of advancement or increased utilization of the digital encounter, I mean, it's here to stay. I mean, it's such an economy of time, and patients are very grateful about it. Less travel, less days out from work, childcare, things of that nature. So there just seems to be a very eager adoption, and I will say that in many ways, the virtual opinions that I have are they're generally very happy encounters. Right? They're just pleased to get you. You're not distracted. They can't believe that they have this one-on-one time with some person who they've researched and that they've acknowledged has some expertise in their particular clinical problem. So it's just made for, I think, for me personally, a very a bit of a deeper connection with the patients, because I'm not distracted either. And as a final note, just sort of like, when we do execute the care encounter, which for me, obviously, as a surgeon, is usually surgical. It's just a meaningful. They understand everything clearly, and typically the outcomes are, quite frankly, really, really good, and with a high degree of patient satisfaction.
Yeah, I think that last point is truly key. And, as someone who sent you patients for a second opinion, you find that, as a doctor, for me, if patients want to get a second opinion, I actually welcome it. And it creates a sense of trust when you say, like, to a patient, look, no, get a second opinion. And when they come back to you, it really does breed that sense of trust, where a second independent provider has verified your treatment plan. And I think that that's very helpful. We've had cases at Best in Class where we've actually done doctor-to-doctor consultations, where we've had our expert doctors, basically consult and do a video visit with the primary treating doctor, who can be, in Maine or what have you. And we found that that's been a very fruitful way to get second opinions. We did have a question from the audience that I want to get to in this section, just because I think it's relevant. So the question was, beyond second opinions, what other ways have virtual visits and digital health been a part of your clinical practice? And for me, one of the major boons in my clinical practice has been for for MRI reviews. So oftentimes, I used to pre-digital health, I would bring patients back in to review their MRIs and what have you. And one of the things I do now is I set aside a portion of my day where I just do video visits to review the MRIs. And it's actually better, because then I do a Zoom share screen and I use my mouse and I point to the areas of problems. And then sometimes for new patient visits where, patients are really pressed and they're, far away, I'll do a new patient virtual visit. Does anyone else have anything they want to add into that question? Good. Awesome. All right. So changing gears for a second here. So, one of the things that we know is that orthopedic surgery, unfortunately, is one of the most over-provisioned or overperformed specialties. And what does that mean? It just means that, surgery is often used as a first-line treatment in orthopedics more so than other specialties. I think that it's important for us to unpack the reasons why. And so, some of my thoughts are that, people may not realize this, but in America is one of the few places where, physicians are paid on a fee for service. And so fee for service means that you get paid for each surgery that you do. So there is an incentive for people who do invasive interventions, whether that's orthopedic surgeons, cardiologists, neurosurgeons, what have you, to look to do procedures. Now, we know that surgeons have a duty to serve, or doctors have a duty to serve, and you ultimately want to do what's in the best interest of the patient. And so, not saying that surgeons want to operate to make money, but there is that incentive there. And so want to get some of our panelists to weigh in on why they think that orthopedic surgery is over-provisioned. So I'll start with Dr. Hecht.
Well, it's a very good point that you raised. A lot of surgeons are looking to do something, whereas we really want to they should be looking to make someone better. And when you make someone better, there's a lot of tools in your tool belt other than surgery. And spine surgery is probably one of the most overutilized parts of the musculoskeletal spend. And, I think if you look at the best spine surgeons nationally, they're the ones that not only are great surgeons, but also recognize the value of non-operative care and see its place in taking care of someone. It's not 100% effective, but it makes a lot more sense than going straight to surgery when this problem hasn't had appropriate care. So I think the mindset of how am I going to make you better is really should be first and foremost, not how am I going to operate, what operation am I going to do to you? So I think if you look at the best surgeons, I don't care if it's spine surgery, sports, they're thinking along those lines. And I think that's some of the things that you've been emphasizing, I think, throughout this call today.
Yeah, and look, I obviously, I do have my biases, but I presented the data earlier, which said that in 57% of our cases, there's a recommendation for non-operative care. So I truly do think that as you raise the bar on the quality of the interventionalist, the quality of the surgeon, et cetera, there is less of a of a need to cut. And I sometimes tell patients who come to me for a second opinion, and their first opinion is recommend surgery, and they say, why did the first opinion recommend surgery and you're recommending non-surgery? And I tell them, look, to a hammer, everything is a nail. Or put another way, if you go to a barber, you're going to get a haircut. All right, so sort of related to that though, how can we then stop the over-provisioning of surgery, right? Are there treatment guidelines to help guide the decision making? I think that I personally think that part of the over-provisioning is as a result of the variability in care and what appears to be a lack of standardization. So let's start with foot and ankle. Dr. Johnson, are there treatment guidelines or clinical guidelines in place that could potentially minimize some of the variability that we see?
I think it really depends on different diagnoses and symptoms that the patient's experiencing. And there are some conditions that are definitely amenable to very specific treatment guidelines. But I see this as an opportunity for thought leaders in my field to create clinical guidelines. We could have an expert network to really help establish these types of indications that can help guide other surgeons throughout the country, really so that we can avoid this unnecessary spend.
Yeah, no, I agree. And, I think that this is something that, there's an opportunity for some of the guiding organizations to potentially put some thought around, and, something that we've thought a lot about at Best in Class in terms of creating guidelines. Well, since you mentioned earlier, Dr. Heck, that spine tends to be one of the overprovision specialties, what are some of the guidelines in spine surgery? I imagine that there are probably pretty strict guidelines, and there's a good evidence base suggesting what is good and what is not good as far as surgery.
Yeah, we've been very proactive about trying to establish effective guidelines. And we've done incredible research that has modified and changed what we do carefully over the years. One of the things that all healthcare organizations despise is, for example, is operating on folks with axial back pain. And we've really tried to emphasize non-operative care for those people. But there are a certain small subset of people that may benefit from that. Whereas we really spend most of our time obsessing about people with back and leg pain or neck and arm pain, trying to really tweak these guidelines to get people better. Again, if conservative care doesn't work, then very often there's a very good surgical alternative. And some of the most landmark studies we've done in spine surgery are the SPORT trials, these sort of spinal patient outcomes research trials that compared operative and non-operative care. And really, the 2-cent conclusion from these studies wasn't that surgery was better than non-operative care, but that when non-operative care fails, surgery may represent a great alternative. The problem with the field is that sometimes people skip the first part and race to the second part. So we're trying to change that paradigm.
That's very insightful. That's very insightful. So we have a question from one of the audience members, and the question is, what are the top 5 recommended procedures where I should send a client to BICMD for a second opinion? So I'll let you, Dr. Johnson and Dr. Heck, think about it while I tackle it from the sports perspective, and Dr. Williams, feel free to chime in here. So I will say, from the sports perspective, meniscectomy or meniscus repair, subacromial decompression or acromioplasty. I will say chondroplasty of the knee, shoulder debridement, and let's see. I'm stumped. I got 4 out of 5, Riley.
I have a little bit of a different take.
Yeah.
I think certainly meniscectomy for sure. I think rotator cuff clearly, and impingement syndrome, put those together. A lot of overindicated surgery in that space. Getting back to the knee, any kind of, ligament reconstruction, not because the ligament reconstruction may or may not be indicated, but because there's oftentimes concomitant pathology that is not addressed during those procedures. So you want to make sure that everything is being addressed to make sure the outcomes are more assured. And I actually do agree with you on the whole chondroplasty. That sort of gets into the world of, I'd say any recommended cartilage repair procedure, MACI, osteochondral autograft, osteochondral allograft, because basically those patients have arthritis, and oftentimes it's such a multifactorial hard recovery that there should always be some kind of second opinion when articular cartilage or early arthritis is in question.
Excellent. Thank you, Dr. Williams. All right, I'll pass it on to you, Dr. Johnson. What are your thoughts? Maybe it doesn't have to be 5. As I was coming up with this, I realized 5 is off the cuff, but if you can get 5, that'd be great. What's your list for foot and ankle?
So definitely number 1 on the list is plantar fasciitis. It's a very common problem, and 99.99999% of people get better without surgery. So it's a rare patient that actually needs a plantar fascia release. Similarly, Achilles tendon surgery, not for an acute Achilles tendon rupture, but for chronic tendonitis, whether it's in the mid-substance or at the insertion, non-operative treatment works the majority of the time and should always be maximized because generally the recovery for surgery is long and involved, and there's a relatively high chance of complications. I often see patients getting acute surgery for ligament repair. So any patient who has an acute ankle sprain does not need urgent surgery ever. And they should always have physical therapy, time of rest, and then physical therapy for at least 3 to 6 months before having surgery. So anytime there's an acute indication for ligament repair in foot and ankle, that's a cause for alarm. And then lastly, flat foot reconstruction, another huge surgery, and most patients really do well with, shoe wear modifications and orthotics and don't need a big reconstructive procedure. And just as a rule of thumb for my number 5, any tendon problem, any chronic tendon problem, not a tendon rupture, but a chronic tendon tear or tendonitis, the vast majority of the times, non-operative intervention should be indicated first, and only unless someone has failed that should surgery be recommended.
And that's a very comprehensive list. Hopefully the BICMD team that's on this call is taking notes so that we can send those lists of conditions to our clients. What about you, Dr. Hecht? What about for spine surgery?
Well, the red flag list in spine surgery could be a whole entire call unto itself. So I would say, for us, the big things are things like revision spine surgery. Second things are people having fusions for back pain. Almost nobody should have that, except in very narrow, rare indications. And I think, and a lot of times, I'm going to use a very broad term, but even something like a fusion type surgery, whether it's in the neck or the back, as a second opinion, because very often a fusion may be indicated at 1 level, but maybe not at 7 levels. And we often see in spine surgeries, people that we would perhaps do a decompression over many levels, but only fuse 1 level of that decompression rather than doing some very long, involved, extensive fusion when a smaller operation would have sufficed. So in spine surgery, the biggest problem we get into with folks is the indication of why they're having the surgery in the first place. But the second problem we get into is surgeons doing too much rather than the right amount of surgery. So in spine surgery, it's really, I would say, revision surgery, surgery for back pain, and any type of multi-level proposed fusion surgery, surgery for myelopathy, all of these things. There's a lot of new things that have come down the road, such as laminoplasty in the cervical spine, that have shown to be way more effective than any fusion in the cervical spine. So I think, and I've always told people, err on the side of getting opinions rather than not getting them, because having good information will help you make good decisions.
That's extremely helpful. All right, perfect. So moving on. So, I think that, I put this in here, because part of our goal at BICMD is to, when we think about the overprovision of care, some people will say, well, doctors actually, or surgeons overprescribe surgery. So why don't we just keep the surgeons out of the equation and don't have have them involved in the process? And what you find is that that actually leads to healthcare rationing. It can lead to the opposite problem, where there are delays in care, and people take a longer time to actually return to work, because there are situations where people actually do need surgery, right? And so what we do at BICMD is we provide a new musculoskeletal front door where we put the expert actually at the top of the food chain, and we have them essentially quarterback the system and figure out who needs the immediate attention, whether that's a workplace injury, figure out a situation where surgery is not indicated, and we send them to some of our premium partners. And so, shout out to Vori, who's sponsoring this webinar and is one of our premium partners, where we actually work with them for digital physical therapy and digital PT, in people who are not appropriate for a surgical intervention or who haven't tried a conservative route. And then for situations where surgery is absolutely indicated, such as, a widely displaced clavicle fracture or an acute rotator cuff tear in someone who's young and healthy, ACL rupture, things like that, we can triage that to prevent delays in care and inappropriate conservative measures in those instances. And so this is what we try to institute in the digital care paradigm. All right, and so this is a bit of a follow-on question, from the audience question, but I think it's an important one nonetheless, and we should give it its time in the sun. And so the question is, when should a treatment plan be questioned? And this sort of is in the mode of, are there red flags in someone's treatment plan that may make you want to get a second opinion? And so I'll ask this question to you, Dr. Johnson. When should a treatment plan be questioned? And you can answer from the foot and ankle perspective or just from a general musculoskeletal perspective.
I mean, I think as a rule of thumb, anytime somebody has a problem that isn't traumatic or isn't an acute problem, meaning, had some sort of, recent injury, there's rarely an indication for an urgent surgery unless it's a broken bone or, a big dislocation of a knee or something like that I'm sure you guys can comment on. So, just beware of any surgery that's deemed urgent. And in most cases, non-operative care can be maximized, outside of those traumatic cases. On the other side of it, when someone's been doing undergoing non-operative intervention for 3 to 6 months and they're not getting better, that treatment plan should also be questioned. Has this patient maximized their non-operative interventions, and really should they be indicated for surgery now? Or have they never even had the proper non-operative interventions, and maybe that plan should be shifted a bit. So, I think you can look at it anytime surgery is being recommended acutely or is told that it's urgent versus someone who's had non-operative care for a long time and isn't getting better. To me, that's when the other care providers should become wary.
That's very helpful, Dr. Justin. And knowing that we have some therapists in the audience, would love to loop in Josh here to sort of weigh in on the other perspective. So Dr. Johnson has talked to us about when a treatment plan should be questioned for someone who's being recommended for surgery. But I would be curious about when a treatment plan should be questioned for someone who is undergoing physical therapy, and are there sort of the non-operative red flag equivalents that something similar to what Dr. Hecht had mentioned previously for spine surgery, but for the patient undergoing PT.
Yeah, no, it's a great perspective, and happy to share. And definitely from a conservative perspective, there are red flags. And so, through a good history and a good physical exam, you might pick up on those red flags where conservative treatment isn't indicated. And so, someone may present to a physical therapist with an acute fracture and not know it. It's not obviously a displaced fracture, but if they're presenting with those signs, you don't want to recommend conservative care when, a trip to the urgent care facility and surgery is likely indicated. There are other considerations, if someone is presenting with neurological symptoms or with symptoms that are outside of what would be expected, for low back pain, for example, they're experiencing, tremors and shivers and night pain, conservative care isn't necessarily the most appropriate option to take there. And, they should be referred out. And so, any of those situations. And then I think on the back end, when someone's not improving, and so although conservative care may be recommended as the first step, as everyone on the call here has highlighted, when conservative care isn't having the impact that you would expect it to be, it's time to escalate to another course of care. And whether that is, as Dr. Hecht mentioned earlier, when surgery is indicated, or other forms of treatment that might be more appropriate to address the concerns present.
Excellent. And we'll have a little bit more on that in a few slides about escalation. So let's switch gears a little bit, and let's talk about digital care pathways. And so in medicine, we like clinical pathways because we like to create some standardization in the way that we treat things. And so as we transition to digital care, we're left wondering what conditions are amenable to digital pathways, and how can we partner with some of our clients, whether they are insurers or self-insured employers to think about conditions that are amenable to digital pathways. And so I'll kick it off with you, Dr. Williams. What kind of conditions do you think are most amenable to digital pathways?
Well, it's been echoed on the call, and I'll just restate it. We as surgeons, I think, are very focused on the establishing of a diagnosis, and that is the main derivative or driver of all subsequent care. And the reality is, in this space, there are going to be very few conditions that result in the emergent surgical indication. So you should have a great degree of circumspection in and around those types of recommendations if you are involved in sort of in the healthcare pathways of folks. The reality is, I think in musculoskeletal health, most conditions are amenable to a digital pathway only because the vast majority of these conditions are not emergent, and oftentimes a beat taken to establish a correct diagnosis is appropriate, as well as to determine which individuals are going to respond to treatment. And I'll just use my own personal experience. Andrew, I have a symptomatic L4-5 disc. It gets me once a year, and for a week I feel like I need surgery, and then I always tell myself relax, and then 2 weeks later I'm fine. So in the throes of being symptomatic, it's good to have some evenness in the involvement. I do think those conditions which are easily elucidated on imaging clearly are amenable to digital pathways, because that is the biggest thing that we rely on in making our recommendation on diagnosis and treatment. There are a few conditions that aren't, like things that relate to shoulder stiffness or knee stiffness are not ideal. Those probably would do best with an in-person visit. Frozen shoulder, for example, that is always a physical exam diagnosis. You can get snookered a little bit. You get an MRI that has a rotator cuff or something like that, and then they come in thinking they're going to need a rotator cuff repair, and they wind up needing just an injection. And then in the knee, particularly post-surgical contractures, for example, persistent pain that's associated with limited range of motion. It's not always going to be totally understood or elucidated on an imaging study. So we're not advocating for the total elimination of the physical exam. In fact, in most cases, all of us would agree that even for those people who are recommended a surgical approach vis-a-vis a virtual encounter, will always fall back on, well, this is all predicated on, what would be a physical exam prior to any kind of procedure. But I just want to circle back to one thing, and I think it was important that Josh brought up. There are two sides of the coin here when it comes to surgery. You can certainly indicate surgery too quickly. We all seen that, but you can also debilitate a patient and waste resources by not indicating surgery after an appropriate episode. So I think that's where the value proposition of our network has great influence and appropriateness. I've been in practice 25 years, and it's an art to figure out who needs a procedure and who doesn't. It's a reading of personality. It's a reading of expectation after surgery. It's a reading on the diagnosis, and a reading on the episode of care as it relates to surgery, and what that experience is going to be like. Do you think they're going to come out the other side? So there can be certainly, there's no problem that surgery can't make worse, but there's also problems that can be made worse by surgical delay. So we were just trying to help in that arena to help referred patients get to that right spot and get the right amount of care.
Yeah, no, absolutely. And I really liked your points about, I think that we're not trying to eliminate all, in person. There are certainly the red flags, the foot drops and things like that. that are certainly, would exclude people. Free to share with the audience, as we think about creating digital, pathways at best in class, we think about some of the procedures and conditions that can be standardized, such as your knee arthritis. Dr. Williams mentioned, lower back pain in the absence of red flags, shoulder impingement. We talked about earlier how that's not necessarily a great thing for surgery, but something that could be very good for a digital pathway. In the sort of with the idea of not leaving people to languish in a digital pathway, because that's oftentimes a problem that we see when we get an opinion from someone who's been under extended non-operative treatment, is lack of progress or lack of tracking of progress. We don't even know if they are progressing. Josh, how do you think about tracking progress for someone who's been deemed appropriate for a clinical pathway? And look, it's a bit of a leading question. I'm very familiar with what Figure 8 does, and obviously admire what you guys are doing. But I think it's important to start to think about how to track progress for people who are being treated conservatively.
Yeah, no, it's a great question, and thank you for the compliment. And I think, part of the reason that I trust and believe in what we're doing is the validity, reliability, and repeatability of those measures. And so whether it's in a digital pathway, in a hybrid model, or an in-person visit, you want the measures that are being taken around musculoskeletal biomarkers to be consistent and standardized and validated so that you can understand, is progress happening? Is progress not happening? Do I need to make a change in my treatment plan? Do I need to make a 180 in that treatment plan? Because as Dr. Williams said earlier, you don't want someone languishing in a conservative model when they need to be escalated to a physiatrist for intervention or to an orthopedic specialist for surgery. And so making sure that the data in each of those touch points is collected in a way that is consistent allows you then to track longitudinally how that person is doing across an episode of care and make some of those evaluations. And I think about it like banking. I can go to the bank, I can go to the automated teller machine, or I can use my app. And if I take $20 out of one of those places, it's going to show up and it's going to be $20 in each of those. But imagine, if I went to the teller and took out $20 and I looked at my mobile app and it said 25, and then I went to the bank machine and then it said 30. That's not a great experience for me. It's not helping me, inform decisions. And sometimes that's what healthcare can be like, is a little bit of that variability in those measures. And so an understanding of progress and recovery and those decisions that need to be made for the best outcome for the patient is hard to do in the absence of that consistent data.
I agree. Couldn't agree more, Josh. One of the things that I think that is helpful about your technology and what you guys are working on is it allows it basically increases patient compliance and patient perception with digital tools. It leads to what I would consider gamification, and patients are able to track their own progress along the digital healthcare pathway. So anything to add to that, Josh?
Yeah, I think, in my experience, there's sort of three things a patient wants to know, and they're working with a physical therapist. And, it's what's wrong with me? And do I have the data to understand what's wrong with me? Once I know what's wrong with me, what do I need to do to get better? And can I see that progress? And once I'm better, what do I need to do to stay better? And so having data, at the outset that says, oh, okay, this is what you need to focus on. Here's the data that shows that, helps them be motivated to address some of those concerns. Having the data that shows that recovery and progress over time, they see that, they become more engaged, they understand that the work they're putting in is having an impact. And then on the back end, once they're better, providing resources in a digital way to allow them to stay engaged, to be educated about their condition, and to promote that behavior change so they can stay healthy is really important. And it's the data at each of those points, I think, that underpins, the foundation of those touch points.
Couldn't agree more with you, Josh. So let's talk a little bit about what the patient journey is in a digital care pathway. So let's walk through what a patient experience should look like with a well-deployed digital MSK pathway. So this is what we envision as the patient journey, and we use low back pain as an example, as something that is highly prevalent. So we think that as we envision the ideal digital healthcare pathway, you start with someone who has back pain. They undergo an initial assessment, risk stratification, and triage, addressing some of the things that we talked about, making sure that there are no red flags and the person truly is amenable for a digital pathway. Then they get triaged to an expert. And so in our pathway, it's a BICMD expert. We believe strongly that by having a touch point early with an expert, you can drive appropriate resource utilization. And so we start with a telehealth consult, and then from there, the BICMD provider can quarterback and basically triage whether or not someone is more appropriate for referral to a center of excellence for immediate in-person care, or whether they are appropriate for digital PT, whether that's a digital therapist or an app-based PT protocol, or even in-person physical therapy. And I mentioned earlier that we have a premium partnership with Vori, and we often find ourselves referring our surgically diverted patients to Vori. And as you can see on the diagram, there is this bidirectional flow. And the bidirectionality means that, for someone who is not tracking well, who is being assessed using the figure 8 tool to not be, improving or plateauing, they can come back to a BICMD provider so that we can opine on if there needs to be a modification or a change in the treatment plan, or whether it's time to, potentially undergo surgery. And ultimately, we think that this patient journey leads to a faster return to work, a faster return to maximum improvement, and better patient satisfaction in the patient journey. And so I apologize for not leaving you guys with much of a Q&A, but the conversation from the panelists was so stimulating. Let's see what questions that we have. So one of the questions that we had was, can you guys give a prediction on what you think is going to be the state of digital MSK in 10 years? That's a tough one. So I'll take that one first, and then let you guys think about it. I think that in 10 years, truthfully, I think that there's going to be a company that has cracked this patient journey and that does it very well. And being honest, Amazon is well on their way to doing it, right? So they recently announced Amazon clinics, and they acquired One Medical, and they're basically collecting pieces of this pie, where basically Amazon clinics is their initial assessment and risk stratification and triage for things that may not potentially be amenable to in-person, but things that need to be escalated will be escalated to a One Medical provider, a doctor network in their provider. And right now, One Medical is primarily medical. They don't have experts, but I'm sure that at some point in the future, Amazon may want to incorporate an expert network and then develop relationships with centers of excellence. And so that's my bold prediction for the future. Does anyone have this burning itch to make their bold prediction?
I mean, I just think that we're never going to go back to holding hands here with regards to, providers being almost exclusively available to patients via the office. I think virtual follow-ups, virtual introductions, virtual discussions about PT and treatment planning and getting more and more practitioners involved and so quite frankly, better coordinated is just the way it's going to be. It has been a breath of fresh air in my practice, because I'm much more efficient and the patients are happy. I really like it. And I do think that, quite frankly, the way I speak to patients now and follow up, because most patients tend to do okay. I think we all would agree that we spend 90% of the time with 10% of the patients. Just the idea that should there be an issue, you can hop on a video conference call with a patient is very comforting. So, I do think its adoption will only continue to expand. The biggest difference, and it's been said a few times on the call, and I'll just reiterate it here, is that just the quality and accessibility of imaging studies in the musculoskeletal place is quite outstanding. I mean, I remember a time when we didn't have MRIs, and you really, really, really were dependent upon a physical examination to come to some sort of diagnosis. Now, I almost use a physical exam to confirm what we see on imaging studies. So I suspect that will become easier, much like the evolution from emails to text messages. The availability of imaging studies in this space will only become easier and less obtrusive, making virtual first opinions much more commonplace.
Amazing. Thank you, Dr. Williams. And I want to thank our panelists for, I know I see more questions coming in. I apologize that we're not able to get to all the questions. I want to thank our panelists for taking time out of their busy schedules to join us tonight on our webinar. We do have a date for our next webinar. It's going to be Wednesday, February 15th, day after Valentine's Day. And registration link will be emailed to you along with a recording of this session. Our panelists for that one will be Dr. Chris Brigham, Paul Signoffi, Adam Seidner, and Kenneth Eichler. And the topic is going to be expert medical opinions, independent medical exams, and impairment ratings. What are they and who needs them? So I hope that you can all turn out, tell your friends, tell your loved ones. And for those who submitted questions who weren't able to get to them, feel free to send me an email. Happy to respond to your questions. It's my last name, Wachuku, b@bicmd.com. Thank you for attending the webinar, and have a good evening and happy Thanksgiving.